So good morning. Thanks very much for the opportunity to be here. It's a great honor. Given the makeup of the panel, I thought I would spend my time talking about what this issue looks like from the perspectives of the front lines of public health and some of the changes we need to be making in our practices to improve our abilities to collaborate in improving the health of our communities. I love the video of the kids this morning to start off the conference, and I thought it was interesting that the first lines out of their mouth were about the United States investing more than any other country in the world, yet having health outcomes that put us towards the bottom of the pack. And the Commission's report started off with this fact as well. In True Confessions, my written testimony starts off with the same fact. And it's a good way to begin the conversation, isn't it? Because it's true and it's pretty upsetting. But it's really not a good way to continue the conversation because it diverts us from the actual truth in three important ways. First, it misdirects attention. It implies somehow that healthcare should be the leading cause of health in our country. And we know that's not the case, as we've heard this morning. Our clinical care system is in big trouble, but the solutions to health in our country, for the most part, lie outside the walls of the clinic and within our communities. Second, this comparison has the ring of a box score. It's a ranking. It describes our performance today, but it somehow suggests that we might do better tomorrow. We don't have a chance of winning a rematch tomorrow. Life expectancy is determined by factors early in life, and so we already know what tomorrow's scores in this country is going to be. Some colleagues of mine at the University of Washington Institute of Health Metrics and Evaluation quantified this. They calculated the average annual rate of increase of life expectancy in the 10 best performing countries in the world. The US is not on that list. And they found that even at those best rates of improvement of life expectancy, it will take the US today 16 years to get to where those top performing countries are as we speak. We are in this for the long haul. And third, to me, and perhaps most insidiously, talking about a single national statistic of life expectancy suggests that all of us are suffering from shorter lives. And in fact, almost nothing could be further from the truth. The analysis that led to that conclusion that as a country we're 16 years behind can be repeated at the county level. Imagining essentially that every county in this country were its own country. And when you do that, you see how misleading this national statistic is. Today, in the United States, some counties are performing close to or at the same level as the best performing countries in the world, while others, particularly in the Southeast, aren't 16 years behind, but up to 50 years behind the best performing countries in the world. Our national average hides profound regional disparity. So I'm not from the Southeast. I'm from King County, Washington, home of Seattle, recreational opportunities, good healthcare, good coffee. And we're actually a county that scores well above that national average, close to the best performing countries in the world. So what am I doing here today? Well, it turns out that even those county numbers are still averages. And if you think the average represents what's happening for every person in your county, you're being fooled. In fact, if you look at my county, King County by neighborhood, and you drop down and you match that every census tract in King County were its own country, you find there's far more variation by census tract within King County than there is by county within this country. And though often separated only by a short bike ride, it's going to take our poorest performing census tracts in King County at optimum rates of improvement, not 50, but close to 100 years to get to where our best performing census tracts already are today. 100 years is too long for the people in those neighborhoods to wait. Our pressing national problem is really about the actions we need to take to improve health in local, highly specific regional neighborhoods that are lagging the furthest behind. Now, the good and bad news in King County is that all our maps look the same. And by I mean that the maps of life expectancy look exactly like maps of heart disease and diabetes and tobacco use and obesity, and essentially any indicator of health or community development that you might think is important. Now, that's bad news because that tells us what the future holds. These maps are telling us that the conditions that are creating short life expectancy today are still very, very prevalent in our poorest communities. And they're telling us that unless we do something different for decades to come, the life expectancy gaps that we see today are going to persist and even widen. But the fact that the maps are the same is also good news because it provides a starting point for a solution, doesn't it? The maps show us the problem we're trying to solve is profoundly place-based. In King County, across multiple causes, a relatively modest number of neighborhoods are contributing the majority of premature illness and death. Poor health in individuals arising not spontaneously, but from specific identifiable community characteristics, substandard housing, inadequate childcare, unsafe streets, lack of transportation, characteristics that are modifiable by community investment. And I think public health and even our healthcare system is beginning to recognize the true root of this problem, and that the pathway to solutions runs through new partnerships, including with our community development colleagues, and a new focus on community investment to improve community health. But the status quo is difficult to change, and so I'd urge the Commission to incorporate 3 related concepts in your new recommendations to help push us all in the right direction. First, deliberately invest community-level health resources in proportion to need. Historically, public health resources have usually been distributed fairly, equally. But to improve health outcomes, allocating attention and resources to communities with the most to gain has the best potential to maximize return on investment. We need to correct our mindset that somehow investments in the neighborhoods with the most challenges are unfairly disproportionate to the more accurate notion that these investments are actually fairer because they're proportionate to need. In King County, we've worked to make these types of policy decisions clearer and easier through local ordinance. Specifically, we've passed legislation that requires an equity and social justice lens be used on all county budget and investment decisions. And although no one in public health has much money these days, in King County we have made this transition, and we now are selectively investing proportionately in our poorest communities. Second, use global health strategies to improve health in our under-resourced communities. Poor health in poor communities is a global problem and arguably has been more effectively recognized and attacked through community-based strategies in places outside the borders of the United States. We need to start adopting and adapting these strategies proven to improve health in under-resourced areas elsewhere. Strategies like community health workers, using technology to leapfrog delivery barriers, linking health and economic development, identifying and building key community assets, to name just a few. Now, we're lucky in Seattle. We're home to some prominent global health organizations with some tremendous expertise, and we've been fortunate to partner with them, as well as our local health organizations, to create a new partnership called Global to Local. Global to Local is piloting community-based global health strategies in 2 of our poorest and most ethnically diverse communities. And I provide some examples of early progress in my written testimony. Third, leverage healthcare financing reform and community health benefits of the ACA to invest in health in neighborhoods most in need. In a future of capitated payment for individual health care, our healthcare system is about to find out that remaining indifferent to the communities from which their patient comes is going to be a shock to their bottom line. Public health should capitalize on this opportunity to partner with hospitals, in part by leveraging the ACA's new expectations for community investment through the community benefit process. In King County, we're working with our health systems to try to make this happen. It's not easy, but a concept that has actually gotten some early buy-off is to extend the idea that the most complicated and costly patients should have additional resources targeted at them. As a health system, maybe we should be doing the same for our communities. Community hotspotting, if you will, special targeted community investment for under-resourced neighborhoods where health and community-based services to address the underlying needs of people are critical. So in summary, underpinning the poor national health indicators in this country is a more nuanced problem of profoundly local, place-based health disparities. Only by directly confronting and correcting these disparities can we hope to see improvement in our overall national health and the indicators that measure it. The solution hinges on investment to improve our community-based policies, environments, and systems responsible for producing poor health in these communities. This work's going to require new partnerships well beyond public health and healthcare systems, and especially with our colleagues in community development who are working in exactly these same communities to achieve exactly the same ends. Working together, there's no time like the present to make all the communities in this country healthy places to live, learn, work, and play. Thank you very much.